Okay, so this is our lecture on benign entities within the breast. Just like in other talks, three basic types of questions. So here's our first case. This is a calx case, and we've got both CC and MLL views. If you remember from the prior talk, you would want to use actual magnification views when you're evaluating calcifications. You can't accurately describe them off of the baseline screener, and you don't want to use your digital zoom. You want to actually bring them in and have real mag views done. So what we're seeing here is some round calcifications that are clustered and have the exact same morphology on both the CC and the MLO view. In other words, they look exactly the same. It's almost as if I copied and pasted the exact same picture and then just changed CC view and MLO view at the bottom. They really look that similar. So this is a classic way to show dermal calcifications. So they're usually in a fold, either in a fat fold or a sweaty breast fold or near the armpit. Just think folds. They typically are clustered or grouped together, and the big trick is that they look identical in a CC and MLO view. If they ask you or forced you to do a next step on this kind of a question to prove that those are indeed tangential or indeed skin calcifications, you could get what's called a tangential view. And this is often sometimes done with a skin marker or a bead, where you place on the calcification and then you do the tangential view. And you want that marker, which would be the orange thing in my diagram here, to be centered right on the calcification when you see the tangential view. If they're apart from each other, like you can see daylight apart from them, that's significant, then that's not in the skin. So next case here, bilateral MLO views of the breast. We'll take just a closer peek here. What we're seeing are these bulky rod-like calcifications with a dash appearance, no dot, dash. Remember that dash is a bad thing. That's like a DCIS thing. But dashes but no dots is more likely this diagnosis, which is a benign thing. I will also tell you that this patient age is 70, which is important, because these secretory or rod-like calcifications only occur in patients that are postmenopausal, because it happens when the duct involutes. Some other buzzwords, some people will say these are cigar-shaped with a lucent center. They typically point towards the nipple, and they're just big, bulky calcifications that you can see pretty well without having to get mag views. The major take-home point here is that you only see these in somebody who is postmenopausal by a significant amount because, like I said, they happen because the duct is involuting. Do not be an idiot and call these on a premenopausal patient. If you're provided an age and it's anybody under the age of 50, you cannot call this. You can eliminate it as a distractor. Next case here, we've got CC and MLO views, and what we are seeing is calcification that looks sort of pearl-shaped or ball-shaped on the CC, and then looks like it's flattening out a little bit on the MLO view. So this change in the morphology of a calcification between these two views is suggestive of milk of calcium. Now, to prove it, I'd love to see an ML view. When you get an ML view, you're going to get that classic teacupping appearance where it really flattens out. can see this thing really flattens out, where here it is here, so we're talking about it's sort of like that, and it's clearly round here. So this guy, this is the one we're talking about right here. So basically it's something that happens in fibrocystic change. Remember, fibrocystic change is really common, and for the purpose of gamesmanship, anytime they're showing you an ML view and it's a calx case, just say milk of calcium. Like, try your best to squint and see that it's flattening or teacupping. So let's say this patient's really anxious and they insist that you biopsy these calcifications anyway, even though it's obvious that they're benign finding. So normally, if you see this here, you can BR2 that. If you make that finding like that, you do not need to BR4 that. You can BR2 that and call that benign. That does not require a stereotactic biopsy. But if you can always biopsy at the patient's request, because what's one more false positive biopsy result, right? Or false negative, whatever. What's one more unnecessary biopsy? This is mammography. Unnecessary biopsies are what we do. So, what if we biopsied this and the pathologist says there's no calx? And we're like, well, I know there's calx. I x-rayed the specimen. There's definitely calx. I can't see the calx. So you have to tell them to use polarized light to assess for birefringence in the setting of milk of calcium. So this is the classic trick for this. If you're suspecting milk of calcium, but you've been forced into biopsying it anyway, you have to tell them to use polarized light. Make a great next step question. Okay, next case. Zooming up here, you can see we've got a round, well-circumscribed mass here that has a few coarse calcifications. So remember, anytime we have a palpable finding or a mass, part of a diagnostic workup, that person's going to get an ultrasound. So we do an ultrasound, and this is what you get. Oval, circumscribed, masked, homogeneous, with this central hyperechoic scar. This is all the classic features of a fibroadenoma. Now, another really important thing, just like the secretory calx are only seen in postmenopausal people, fibroadenomas should be seen in a premenopausal person because these things are estrogen dependent. They peak around age 30. They can grow in certain situations, pregnancy. Some people will say they'll grow in pregnancy because they're hormonally responsive, just like a fibroid in the uterus will grow with estrogen sometimes during pregnancy. So these are all the classic features. Here's another one. If it's in an older person, what they do is they will involute, and the way that occurs is that they will have peripheral calcifications that will develop over time. And the buzzword for these calcifications is popcorn. They are sort of these bulky. This is a type of benign calcification, popcorn calcification. If you use the word popcorn calcification, you are saying that this person has a fibroadenoma. So this is what we're looking at here. These are 3 mammogram x-rays taken of the same patient over a course of time. You can see that there's progressive, these are peripheral calcifications that are occurring more and more and more over time. So this is what you expect. That does not make it more suspicious. That makes it less suspicious. So you can BR3 this on a baseline exam. If you see something like that and it's not a baseline exam, you have to BR4 it. And we'll talk more about that in a little bit. It's going to talk about MRI in one of the upcoming lectures. But just to touch on it quickly, because it is a classic way to show a fibroadenoma, a T2 bright lesion that has these thin, non-enhancing septations talking about this guy right here and this guy right here. This is classic for fibroadenoma, and they tend to have a type 1 enhancement pattern. Those types are the same as they are for the prostate, where you're supposed to think about these things like the stock market. Type 1 is you bought your stock and it continues to go up, and that's good. That's what you want it to do. Type 2 is sort of your intermediate scenario where you bought your stock and it goes up and then it like plateaus out. And then type 3 is the bad scenario where it goes up and then it crashes quickly. And that's the rapid washout. That's the bad one. So bad things have rapid washout. Stock market falling is bad. Good things have sort of a progressive enhancement curve. And since a fibroadenoma is a benign entity, that is the enhancement pattern that you can expect. They do not have to enhance, and when they don't, that makes it even more confident that it's a benign entity. So this time we have a mass, but the patient is 50. It's really important to pay attention to that, guys, when they give you that age, especially with mammo. They are leading you in one direction versus another. So we got a mass, 50-year-old. Because it's a palpable and it's a mass, they're going to get an ultrasound. They cannot leave the department without an ultrasound. This is a diagnostic workup now. And what we see is a lesion that looks pretty damn similar to that fibroadenoma. Well circumscribed, homogeneously hypoechoic. So side by side, these are path-proven cases actually. This was path-proven fibroadenoma. And this was a path-proven phylloides tumor. So the take-home point here is that if you see a thing that looks like a fibroadenoma, but the patient is 50 or 60 years old, don't call it a fibroadenoma, you call it a phylloides tumor. And these are not benign. I know this is a lecture on benign entities. This is the one entity that I'm going to show that is not benign. I just waited to show it because it looks so much like a fibroadenoma that I wanted to make that comparison. These things grow rapidly. They have a high recurrence rate. You need wide margins when you cut them out. They can met, and they do met hematogenously. Big take-home points here. Older women, not in the same age group as a fibroadenoma, and they tend to mimic a fibroadenoma. If you were given no age, you would not be able to tell them apart. Okay, so next case here, we've got a cluster or group of round calcifications. So how do you handle that? So remember that calcifications are described with their morphology and then their distribution. And the distribution really can make you think whether or not this is a benign thing or a bad thing or an intermediate thing. So quick review, scattered and regional calcs are considered benign patterns. Linear and segmental are considered bad things. Those are going to end up getting biopsied. Grouped and clustered is sort of intermediate indeterminate. So you can use a BR3 on a group or cluster of round calcifications on your baseline exam. So let's talk this through. What does BI-RADS 3 mean? Remember, BI-RADS 5 means that there's like a 95% chance of malignancy. BI-RADS 1 or BI-RADS 2 basically means there's 0. What does BI-RADS 3 mean? BI-RADS 3 means there's a less than 2% chance of malignancy. That is a highly testable statistic. Remember, since mammo has such limited actual information in it with regard to pathology, that trivia like statistics tends to become fair game. The more shallow the pool of information, the more random the trivia becomes. So let's walk through a workup. Let's say that you have a 40-year-old patient who shows up for their first screening mammogram, and you see these round calcifications on it. So because you can't characterize calcifications on a screener, you need mag views. You BR0 it, bring them back, recommend mag views. They come back for their diagnostic and they get mag views, and you say there's a cluster or group of round calcifications baseline exam, they've never had a mammogram before, you don't know if they're new or how long they've been there, you can BR3 that. Situations where you could not do that would be if you had a prior and they weren't there and they're now new from the prior, then you would have to BR4 them. If these same round calcifications were not grouped but they were instead in a regional or linear distribution, you can't BR3 that. That has to be a BR4. That gets a biopsy. So you have to have the morphology of round, the distribution of either grouped or clustered together, and it has to be on a baseline exam to make for a BR3. You can never call a new finding a BR3. All of these things, anytime you use that, and there's only 3 specific scenarios when you can, it must be off of a baseline exam that then gets called back. So, baseline screener exam, you're always going to BI-RADS 0 it. It's going to get a diagnostic workup, and then you can call it a BI-RADS 3. An exception would be if the patient came in with a palpable finding, although that is controversial. There are papers that say that palpable findings can still be benign and BI-RADS 3'd, but there is also classic teaching on the subject that says that a palpable finding can never be BR3'd. So it's controversial. I don't think it'll be asked because of that. So just don't worry about that. BI-RADS 3 is going to be used in a scenario where you've had a baseline exam, BR0'd it, it's got additional workup, then you can call it a BI-RADS 3 if it meets specific criteria. Then what do you do with it? You're going to want to follow it every 6 months for 2 years, assuming there's no change in those intervals. If there's any change at all, it's going to go get a BR4 and then it's going to get biopsied. So you're basically following it for stability just like a pulmonary nodule, and then after 2 years you can call it benign, just like a pulmonary nodule. So here are the 3 specific scenarios where you can use BI-RADS 3. Grouped or clustered round calcifications, remember not linear, not regional, those would be BR4. If it was scattered throughout the breast and they were round, you could BI-RADS 2 that. Grouped or clustered round calcs can be BR3'd. If you have something that looks exactly like a fibroadenoma, again, this is on a baseline exam. A 40-year-old comes in, they get called back for a mass. You get a diagnostic compression view and also an ultrasound. All the features are just like a fibroadenoma. It's a well-circumscribed oval mass, homogeneous, echotexture, abrupt margins, etc. You can BR3 that. If the patient requests that you biopsy it, you biopsy it. You don't tell a patient no that you're not going to biopsy something. If somebody would ask that on a question, anytime a patient requests a biopsy, you give it to them. The third scenario is an asymmetry of the breast tissue with interspersed fat. So you can see that here there's a fatty breast that has a little bit more breast tissue on one than the other. It's asymmetric. You can BR3 that if it's on a baseline exam. All right, next case is this. This is another one that's very classic for trickery here. And what we've got are bilateral, well-circumscribed masses. So, screener, this can actually be BR2'd. Bilateral, well-circumscribed masses, and they have to be multiple, at least 3, on both sides. This does not work for unilateral multiple masses. If you have multiple masses in one breast, one or all of them are getting biopsied. This is a bilateral thing. It has to be very specific for you to be able to pull that off. Next case is we've got CC and MLO views, and we've got a equal to density mass that has areas of fat density. Notice I didn't say low density, I said fat density, almost as if it was a breast within a breast, and that's a buzzword. So this is a hamartoma. That's what a hamartoma looks like. It's a breast ant mini. Breast within a breast is the buzzword. It's a fat-containing lesion. Fat-containing lesions are BR2s. They are benign by definition. So fat-containing lesions, there's 5 of them you need to know. Hamartoma that we mentioned, breast within a breast. The second one is seen only in a lactating patient. That's very specific. You can only have this pathology in a lactating patient. The classic location is in the subareolar position. And if they show you on ultrasound, the classic way to show it is with a fluid level. So this is a galactocele. Again, only seen in a lactating patient, subareolar position, fluid level on ultrasound. You don't want to biopsy these things if you can avoid it because you can cause a milk fistula. The third thing is going to be a palpable mass that blends into the remainder of the breast tissue. On physical exam, you're not really going to feel anything. And then on ultrasound, you're going to have a well-circumscribed mass that's isoechoic to the fat. And it's just going to feel like a lipoma does anywhere else in the body. You can have, one entity that goes by 2 names, which is fat necrosis or oil cyst, depending on the size of the lesion. And it's this sort of egg-shelled thing that's very lucent fat density in the middle. These occur in the history of trauma. If you've had a car accident with a seatbelt injury to your pendulous breast, you could end up with a bunch of fat necrosis. You see it in post-op person. They often will have fat necrosis around their surgical incisions. And then the last one is this, which notice that is in the posterior third of the breast. Sort of the same as this guy, same as that guy. Sometimes these intrapulmonary or intramammary lymph nodes will show up in that posterior third, and they are fat containing and they are benign, and you have to sort of know what they look like. You see them all the time. So these are your fat containing lesions. Those are 5 of them. 6 names, 5 entities. All of them are benign. All of them can be BR2'd. Okay, next situation is a palpable finding. So that's going to get an ultrasound. So we've got this thing, well-circumscribed mass, sort of looks like it might be fibroadenoma, but it was new from prior exams, so it's going to get biopsied. So that gets BR4'd. Got a new mass, is always going to BR4. So the results are back. We BR4'd that. We did not BR5 it. We decided to BR4 it based on the ultrasound characteristics. Just looked really well circumscribed. So this is what the pathologist tells you it is. This big, scary-looking bunch of words. So you basically have 3 options, right, when you have biopsy results come back. Benign things will go home, high-risk things will get excised, and cancer, obviously, will get excised. So what pathway are you going to send this patient? So benign is what you're going to say. Now, typically, the follow-up for these things is either 6 months or a year. The 6-month follow-up would be an institutional thing, depends on at your institution on whether or not you follow up every person who had a biopsy for 6 months. But technically, they're benign, and if given the choice, I would do a 1-year follow-up. This does not need surgical excision, does not need a surgical consult, does not need chemotherapy. The trick on these is that it's a big, scary sounding name that is a benign process. Next case here, CC and MLO views. We've got a palpable marking next to a tubular structure. It's a palpable finding, so palpable findings always get ultrasounds. And in this case, we again see this tubular structure. It's hypoechoic, a little bit of flow along it, but not completely through it. So this is a thrombosed vessel. This is Mondor's. So it's a Yeah, buzzword is a tender, palpable cord. It looks exactly like you'd expect a thrombosed vessel to look like. It is superficial vein. You do not need to anticoagulate it. All right, one more case here. So we've got lymph node. Take a closer look at this lymph node, and we can see that it has multiple hyperdense punctate calcifications or areas of mineralization. And this is classic Aunt Minnie for gold therapy. Apparently back in the Stone Ages, rheumatoid arthritis was treated with gold therapy. Very dense calcifications, and they almost looks like metal within the lymph node and the axilla. If they wanted a next step or something like that, it would be like query history of rheumatoid arthritis or rheumatology consultation or something like that. So this is the end of the lecture, and the next talk will be on the male breast.